abnormal firing of neurons leading to the generation of some electrical potential leading to abnormal body part of the part as we have already seen. So epilepsy is a common condition worldwide with approximately 50 million people suffering from it. ऐसा नहीं है कि दो चार लोग ही हैं, like a lot of populations are suffering. It is a heterogeneous disorder characterized by epileptic syndrome, having different etiology, diverse etiology, and prognosis may be variable. कुछ की prognosis अच्छी है, कुछ की थोड़ा सा epilepsy जो difficult to treat होती है, उनकी prognosis थोड़ी सी खराब भी होती है, जिसमें multidisciplinary care is also required by the various departments like occupational therapy, physiotherapists. All are needed to give the proper care to the patient. And epileptic seizures are quite common, affecting between 8 to 10% of population throughout their lifetime and accounting 1 to 2% of the presentation to the emergency room, and about part of these with the first seizure with a different type. So they may present anywhere, around, and they sometimes they might do admission in the hospital. If not properly cared of their airway breathing circulation during the time of epilepsy, they may they may take a toll also, basically. So this slide shows you the classification as per the International League of Association of Epilepsy. So it is of 2017 classification. It is quite in 2025 new classification which had added some point to it is already being come. So epilepsy, as you can see, can be defined divided into focal, generalized and unknown onset. For your understanding, we start with focal. Focal means some part of the body is being involved. Only some part. Rest of the part is normal. Generalized means whole body part, as we have already seen demonstrated here. And unknown onset, unknown जिसका कोई पता नहीं कि कहाँ से start हो रहा है, कहाँ से नहीं. So focal onset further उसमें divide कर सकते हैं. Focal with aware or impaired awareness. ठीक है ना? Aware or not aware. Aware means movements are there and person is aware of surroundings also. When abnormal focal movements are there but person is not around, it is known as impaired awareness. इसमें motor onset भी हो सकता है, that is you can see the body part moving, muscle movement basically. Motor means muscle movement you can see, and sometimes non-motor onset. So other part of the body, इसमें other sensation like autonomic, behavioral, cognitive, consciousness level and emotional sensory. So these are the non-motor onset type of seizures are there. And motor onset means there are certain automatic, abnormal automatic response. Then atonic बिल्कुल relax हो गया that part of the body. And clonic means jerky movements, repeated jerky movements. Sometimes epileptic spasm like this type का हो गया, एक spasm जो focal, hyperkinetic large movements, multiple movements. Then myoclonic, you can see that if you see the like muscle of the body, when the body part is exposed, you can see the twitching of the muscle. That is the focal part. Also that clonic also, myoclonic and clonic also. Tonic means the tone of the body. Tone, all of you understand the tone basically. Let's see that stiff हो गया, that becomes increased tone of the body is there. Likewise, same as the generalized onset also, there will be tonic movement and clonic, myoclonic. These are various types of. You might not go into detail. There are also that generalized can be non-motor, previously known as absent seizure also. They may be typical, atypical, myoclonic and irate myoclonia may be there. And unknown onset can be motor as well as non-motor also, in which various types are there. And then other things are there. Sometimes epilepsy starts with the focal and then spread to the whole of the body. Then it becomes classified into focal to bilateral, tonic-clonic, generalized basically. And certain other type is not classified, it is known as unclassified. This is in rough all of the classification of the epilepsy is there. So, as per the definition, epileptic seizure has been defined by the International League Against Epilepsy as a transient occurrence of signs and symptoms as a result of abnormal, excessive or synchronous neuronal brain activity. So, इसमें multiple brain activities, the firing of neurons are there leading to abnormal, excessive or synchronous neuronal brain activity. At least two definition में क्या है कि कितनी बार epilepsy से जिसको आप epilepsy बताएंगे, ठीक है? At least two unprovoked or reflex seizure occurring more than 24 hours apart. One definition. And unprovoked seizures and the likelihood of subsequent seizures similar to the overall risk of recurrence at least 60%, accompanied by the clinical EEG or neurological imaging changes and after two unprovoked seizures occurring within the next 10 years. Or patient is having some diagnosis of some epileptic syndrome, we will discuss in the subsequent slide. So it means person should have at least two unprovoked seizures within around 24 hours. Or unprovoked single unprovoked seizure along with some abnormality in the brain or imaging or electroencephalogram, and it will be defined as an epilepsy. Coming to the etiology, why epilepsy occurs? So it is cause can be of the seizure can vary by age. Some are common across all ages, while others are age specific. In newborns, seizure typically indicate in identical condition like neonatal encephalopathy, metabolic disorders, or infection affecting the central nervous system. Older infant and young adults, young children, febrile seizures are predominantly caused related to the age. Febrile seizures usually limited up to 5 years of age. After 5 years of age, that seizures, most of the seizures are permanently gone. Structural etiology is identified through neuroimaging, which reveals abnormality that correlates with clinical sign and EEG data. Discordance between clinical and EEG findings related to imaging suggests that observed structural abnormality may not be the cause of seizure. Some structural differences in seizure can be due to genetic, acquired factor, or combination of both. The etiology can be varied as per the age. So this slide shows you the various causes of epilepsy. So epilepsy and related disorders can be in childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and Dravet syndrome. These are the epilepsy syndromes are there. When there is in the brain there are structural lesions, they may precipitate any abdominal finding. The condition can be stroke, tumor, many neurological disorders like Alzheimer's, vascular malformation, trauma to head, neuronal development, lesion in which cortical dysplasia, hippocampal sclerosis may be the reason of having epilepsy. Certain metabolic and systemic causes like mitochondrial disease, even hyperthermia can lead to seizures. Hyperglycemia can, when the blood glucose level is very high, they may lead to a seizure. Hypocalcemia, hyponatremia, encephalopathy by either liver disorder or kidney disorder may lead to the generation of seizure. So you can see the metabolic causes are also there. Then certain encephalitis and autonomic condition like encephalitis, anti-NMD receptor antibody, in which there is autoimmune infection of the brain is there leading to the autoimmune encephalitis. And anti-leucine rich glioma activated one antibodies are there. And certain infectious causes like neurocystic psychosis, you might have heard of. There is some neurocystic psychosis in the brain leading to the seizure. So the first presentation is seizure होता है. When we do the imaging, we will find some abnormal lesion in the brain. From certain HIV infections, cytomegalovirus virus, cerebral toxoplasmosis, and tuberculosis may lead. They all leads to seizures. So you can see the etiology can be described by these events. Certain critical aspect, particularly in the children, young adults, they are suffering from so many syndromes, right? The seizures in younger children are significantly different from those other older children and adults. Those older than 6 years tend to have seizures similar to the adults, while younger children have fewer complex behaviors, especially focal seizures with impaired consciousness. So causes of seizures may be some familial causes may be there under the age of 6 years. After that, the causes are relatively similar. If you study, I will be discussing certain epilepsy syndromes in the children. First is West syndrome, which occurs between the age of 3 to 12 months. It consists of triad of epileptic spasm, hypsarrhythmia, and psychomotor retardation. It may also be precursor of another epilepsy syndrome, also known as LGS, Lennox-Gastaut syndrome. Next syndrome is Dravet syndrome, onset in the first 18 months of life, which may be the focal seizure, some with secondary bilateralization, usually triggered by fever or hyperthermia. It can be absence type, myoclonic, focal, and reflex seizure may also occur in the preschoolers for photostimulation or hyperventilation. Initially, intellectual capacity is not affected, but over time, as the number of seizures increases, cognitive impairment can be severe. It means if the untreated epilepsy is there, it is going to cause a certain damage to the brain, leading to the overall cognitive decline over the period of time. It not control the time. Next comes febrile seizure, as we already discussed. It can be simple or complex. Simple febrile seizures are usually generalized, last less than 15 minutes and do not recover over 24 hours period. Complex seizures also occur after the age of 6 years. Usually, these febrile seizure remains under the 6 years. After that, they are a little bit of rare, but sometimes they do occur accompanied by fever or not by the basis of Dravet syndrome, myoclonic atonic epilepsy, and focal sclerosis. They are focal prolonged. They may recover over 24 hours. Next syndrome is benign Rolandic epilepsy. Rolandic basically it's an area of brain. There is a problem in that area of brain leading to that sort of syndrome. It is self-limiting epilepsy presented with a focal seizure with chronic or clonic activity as a part of the face or tongue or oral testing. So that because the involvement of Rolandic part, that abnormal movement limit to the face, tongue and oral areas. And focal seizures are more frequent in the young children, and progression to bilateralization is frequent during sleep and may be associated with post-critical deficit, thoughts paralysis. Psychomotor development in this situation is usually normal because the area is only the facial part. Coming to the typical absence seizure, the onset is sudden and lasts 30 seconds and can up to 50 times a day and can be completed by the 40% case of generalized tonic seizure. It may be associated with the palpable mindfulness and may be triggered by hyperventilation. So absence seizure means the obvious patient become like silent. You are talking to the patient, he remains silent for some time, 20 seconds. After that, he regains consciousness, but he doesn't know anything about during that time. He may be looking at you and having just a stare look at that time, and sometimes if sudden fall may be associated with that type of absence. So many variations are there, but it is only over a brief period of time, and they occur up to 50 times a day. So लोगों को पता ही नहीं चलता कि उसमें ऐसा हो रहा है, unless properly उसको observe नहीं किया जाए, ठीक है? Next syndrome is Lennox-Gastaut syndrome. It includes a triad of generalized tonic, atonic, myoclonic, and atypical absence seizure, peak wave, easy interactive change, and psychomotor retardation. Nocturnal tonic events are characteristics of the syndrome but are difficult to recognize without video elastographic monitoring. So sometimes for the diagnosis of epilepsy, we have to monitor the patient under the video imaging. ठीक है, patient बोल कुछ रहा है लेकिन unless you observe properly night में लगा कर तो how the patient sleep during the night and or having every abnormal movement in the which are comes under this category, we can diagnose the patient very well by doing the video electroencephalogram. Negative prognostic factor are psychomotor retardation, preceding seizure, history of epileptic spasm, and symptoms before the age of 3 years, increase the frequency and recurrence of non-convulsive status epilepticus. These are the negative prognostic factors if they are present. Next common syndrome is juvenile JME or juvenile myoclonic epilepsy. It is the most common form of genetic epilepsy. Patients usually present with a generalized tonic seizures, often caused by sleep deprivation, alcohol ingestion, stress, or intermittent light stimulation. Although on thorough history, most patients have had morning myoclonus. So this is how you can differentiate between the various epilepsy syndrome. Now coming to the focal epilepsy syndrome. Focal epilepsy can develop at any time of the life, and the etiology varies according to age. And as does the semiology vary according to the location as well. Temporal lobe epilepsy. Now focal epilepsy means only certain part of the brain is involved, and you all know our brain has each and every part of the brain, be it right or left, and other cortical subcortical area. They have their particular functions are there. Okay, so whichever lobe is involved, yeah, having some abnormal neurons there, they may give symptoms to that brain, that area. By delineating that findings, you can very well correlate the patient to this type of epilepsy may be there. Like in temporal lobe epilepsy, it is commonly present in various auras, basically deja vu, and epigastric sensation. These are some psychiatric terminology there. Presence of abnormal scenario, उसको लगे कुछ और ही चल रहा है, ठीक है, किसी और दुनिया में आ गया है, तो that brief interval may be a feature of temporal lobe epilepsy. Aura may be accompanied by impaired consciousness and motor automatism or dystonic posture. And non-dominant lobe involvement can lead to symptoms like nausea and vomiting. Okay? We have two sides of the brain, right and left brain, and most of the brain, most of the people's left brain is very much active. Okay? You can say dominant one, left side. But in the 60% of the person, right side is also dominant. So if one part of the brain is dominant, then other part is non-dominant. If the environment is the non-dominant temporal lobe, so that features can be different. Okay, not exactly to the dominant one. The seizure lasts approximately 60 to 90 seconds, often resulting in the post-ictal confusion, especially in the dominant lobe damage. The focus in the lateral temporal lobe affect eloquent area like Wernicke area. Temporal lobe में हमारे various organ like if Wernicke's area is there, okay, if involvement is there, the patient may have language disorder, auditory aura may be there. And involvement at the temporal occipital junction can lead to vertigo or visual area because some fibers from the auditory or that balancing part are there, they may have vertigo and some visual aura there. And then that aura may progress to capped gaze quickly followed by generalization of the symptoms. Now next is frontal lobe. So there is involvement of frontal lobe areas, which is the second most common type of epilepsy location. Seizures are predominantly motor, short in duration. Frontal basically हमारा body area cover करता है, ठीक है, body के most of temporal थोड़ा auditory and psychiatric part cover करता है. That's why the aura is more common in temporal lobe epilepsy. Seizures are predominantly maybe motor, short in duration, and often occur nocturnally. The post-ictal periods features a rapid return of awareness, generally accompanied by motor deficit for some time, known as towards paralysis. Semiologically, it is characterized into the primary motor area, somatomotor area. The various areas are there. We should not go into detail. Most regions exhibit motor phenomena. However, the posterior opercular zone may be confused with temporal lobe epilepsy. Symptoms may include gaze capping, automatism, head and eyeball deviation, as we are saying in typical epilepsy. Asymmetrical tonic seizures manifest as tonic fraction of one arm and extension to the opposite arm, sometimes affecting lower limbs, linked to the activation of the broadness area. Next is our parietal and occipital lobe epilepsy. Occipital lobe basically our वहाँ पे क्या होता है mainly visual area, ठीक है ना, visual area, and parietal is for sensory area. In this case, the localization is much rarer than other. It is rare as compared to the temporal as well as frontal. The occipital vision is associated with the elementary visual hallucination because it is that in occipital area our visual area is there, तो वहाँ पे visual hallucinations होंगे. Unlike the temporal lobe where complex visual hallucinations occur. Parietal lobe epilepsy may present with the somatosensory aura. So there may occur brief abnormal sensation in the body when the parietal lobe is involved. Both types can spread rapidly and may be associated with semiological element. After knowing about the various types of epilepsy diagnosis, some juvenile syndromes and some localized syndrome, temporal, parietal, occipital and frontal lobe epilepsy, so we need to come across how to make diagnosis of epilepsy. After seeing this, obviously, clinical is the must part. We have to observe the patients also. But there are some investigations also. Let's see about it. So diagnosis, as I told you earlier, is epilepsy primarily clinical. So it means you have to observe, you have to take the history of the events, कितने समय हुआ, कितने ब्रेक और फंक्शंस लॉस हुई, automatism like data ball incontinence हुआ कि नहीं हुआ. You have to ask with additional test. ठीक है ना, इतना अगर आप हो गया तो then you perform the additional test to get the supporting evidence of epilepsy. And sometimes we have to differentiate with the other pathology, differentiating an epileptic seizure from other pathology is crucial to the correct diagnosis. We will discuss some different diagnosis after some slide. And differential diagnosis should consider all causes of altered sensorium, mental status, motor and sensory manifestation as these can mimic. So before labeling a patient to the epilepsy, we have to do all these things. At least we should not miss any treatable cause of epilepsy. You can see treatable cause of seizures basically. Once you treat the treatable cause, seizure may not occur again. But in epilepsy, once seizure occurs, the patient may have the risk of developing seizure in the whole of life. Then experienced epileptologists, जो person who are seeing more epilepsy patient can often recognize various forms of epilepsy through clear historical event data. Challenges in achieving definitive diagnosis arise from the atypical seizure presentation, incomplete patient history, and overlapping syndrome. So most of ourselves recognize epilepsy as a only most of the time कि जैसे सीजर आपने डेमोन्स्ट्रेट किया सीजर से, लेकिन अगर सीजर नहीं आ रहा है तो लाइक आई हैव डिस्क्राइब मैनी थिंग लाइक पेशेंट को सेंसरी सिम्टम भी हो सकता है, पेशेंट को विजुअल ऑरा भी हो सकता है एंड विजुअल हेलुसिनेशन हो सकता है, फीलिंग ऑफ एब्नॉर्मल थिंग्स हो सकती है. दैट इज आल्सो अ पार्ट ऑफ एपिलेप्सी व्हिच इज वेरी डिफिकल्ट टू डायग्नोज बाय हिस्ट्री. Because once we see the motor, it is okay, it is epilepsy. But when the sensory symptoms and automatism is there, it is very difficult to diagnose epilepsy in that sense. Although those things are little bit of rare. Now come to the examinations in epilepsy. All of us know that EEG, what it do? It records the electrical activity of brain. When the electrical activity is abnormal, then we can say it is some abnormal focus is being generated. That is impaired. It helps to complete the diagnosis of epilepsy, choose appropriate therapy, monitor response to treatment, and determine candidates for anti-epileptic drug withdrawal and surgical localization. So, in which we can sometimes find focal spike or sharp wave with associated slowing of the electrical activity on the area of spike. Next is video electroencephalogram or long-term monitoring. So video EEG recording is useful and it is indicated in the patient with suspected psychogenic seizures for epilepsy syndrome classification, and especially in those with pharmacoresistant focal epilepsy, possible candidates for the epilepsy surgery also. It is also helpful in intensive care unit in the evaluation of encephalopathy and non-convulsive status epileptic. So it is also useful. It is not possible for everyone to be with the patient all time. And sometimes it gets difficult. Okay, to like sometimes psychogenic seizures are all there. Maybe hyperventilating seizure. So that diagnosis we have to do the video EEG. Capturing seizure activity simultaneously on the video recording and EEG. If this EEG sampling may reveal the evidence of incorrect abnormalities. You will get the more idea once you have the evidence video EEG of that episode of epilepsy in the video EEG. Next is for structural reasons, what we can do. We see any tumor and all, we can do the CT scan, and usually order in the emergencies in patients when the first seizure episode. जैसे ही इमरजेंसी हमारी इमरजेंसी पेशेंट आते हैं तो we first CT scan में आते हैं. Sometimes we find the bleed is there, sometimes we find the ischemia is there. Sometimes we find a granuloma is there in the CT or MRI. So for the structural lesion, structural cause of epilepsy, we have to do the CT scan or MRI. So like MRI will also help us to identify the underlying etiology of focal or generalized seizures. The optimal MRI technique for the patient with focal seizures these are the certain technical things are there. But structural injuries like mesial temporal sclerosis, neoplastic lesion, vascular malformation, and development disorder lesions can very well picked up by these imaging techniques. Next is PET scan. When we are thinking the patient is having some like part of surgical evaluation of persistent focal epilepsy, to see exact what the patient's body part, patient's brain part has become hypermetabolic. The hypermetabolic activity we have to do the PET scan, which are very difficult to pick in the normal routine MRI or CT scan. So we can find ictal hypermetabolic, or intestinal hypermetabolic things in the PET scan to see the effect of seizures. Next are laboratory tests, routine laboratory tests like CBC, blood glucose. Blood glucose may give you hypoglycemia or hyperglycemia. Both hypoglycemia and hyperglycemia may lead to the seizures. And electrolyte, panel-like hyponatremia is a well-known risk factor. Hyponatremia, hypocalcemia, these are the well-known risk factors of developing seizure in any patient. Then the CBC count, toxicological screening, and toxin can may lead to seizures. Then sometimes infection like viral encephalitis, meningitis, meningitis, then we have to do the lumbar puncture, and extreme hypoglycemia or hypoglycemia can cause provoked epileptic seizures. So these, if any finding we find during this panel, these are the causes of treatable cause of epilepsy. Okay. Then genetic testing is obviously it is needed when the patient is suffering from the childhood epilepsy or some epilepsy which is running into the family or some related syndrome we are thinking of, then we can offer the genetic testing. So there are so many genes are to study which is the beyond the scope of this lecture over here. Now come to the differential diagnosis or epilepsy mimic. After knowing about so much of epilepsy, we should know something about the differential diagnosis, how we can confuse the seizures with the various various conditions also. Let's see. So these are the conditions that they resemble epileptic seizures but are caused by non-epileptic factors requiring careful history, observation, and sometimes electroencephalogram to differentiate. So first is symptom. ठीक है, it is very common. Patient सामने खड़ा धड़ाम से गिर गया, ठीक है ना? So it may confuse with the absence seizure. इसमें what happened in this? It is a transient loss of consciousness due to decreased cerebral perfusion, ठीक है? Because of any reason. Patient might be taken like antihypertensive or BP come or suddenly गिर पड़ा. So that is one of the vasovagal. Often triggered by prolonged standing, emotional stress or pain. So you might have some of you might have experienced while taking the rounds of prolonged standing. Sometimes some person might feel dizzy also. So this is the symptom episode. May involve myoclonic jerk, marking it hard to distinguish from seizure, rapid recovery without post-exposure perfusion. It is the hallmark of it. जैसे आप पेशेंट लेटेगा, पैर ऊपर करेंगे, perfusion becomes all right, so it becomes all right without giving any evidence of intravenous perfusion, right? Next is psychogenic non-epileptic seizure, also known as PNES. It is functional neurological disorders. Functional means there is no abnormality in the brain nor in the electroencephalogram. Sometimes it is a psychiatric manifestation that you may have. So patient with a bizarre movement which is not typical for any of the epilepsy types basically. Maybe of prolonged duration, usually epilepsy short होता है, ठीक है ना? 1-2 मिनट में ही सीजर्स आएंगे, उसके बाद फिर नॉर्मल आएगा. तो इसमें पेशेंट इज थ्रोइंग सीजर्स ऑन इट्स ओन बेसिस टाइम एंड pelvic thrusting is there which is not a feature of epilepsy. So no easy correlate typically occurs in the emotional or stressful context. You see, we have to it means we have to see the emotional context of the patient also. In what circumstances that is a psychogenic non-epileptic syndrome. Eyes are usually tightly shut, which is uncommon in epileptic seizures. Okay? So sometimes it is also very common, more than the epilepsy syndrome itself. Next is transient ischemic attack. ये vascular things in the brain. There is transient diminution in the blood supply leading to these type of episode, and they lead to a sudden focal neurological deficit like hemiparesis or aphasia. You resolve within minutes to hours. The thing is that patient becomes all right. But still it is very difficult to recognize also. Maybe thoughts paralysis में भी ऐसे ही होते हैं, तो it is very difficult. It is quite similar to the epilepsy. Can be confused with the focal seizure, especially in the elderly. Next is migraines. Migraine have various parts. Okay? Migraine is a vascular headache is there, which has various types, in which some hemiplegic or basal migraine, which can confuse with the epilepsy. Then aura phase is also there, in which the patient might experience visual disturbance, sensory symptoms, may be focal seizure. Hemiplegic migraine can resemble a post-acute thought paralysis, so it is also very difficult to differentiate between the typical epilepsy. So hallmark is that headache follows neurological symptoms helping differentiation. So headache के बाद में अगर start होता है, you can think it may be of migraine with basal migraine or hemiplegic migraine is there. Next is sleep disorders or patients who are suffering from narcolepsy or parasomnia or abnormal sleep pattern. Parasomnia is night terror, sleepwalking, occur during non-REM sleep. Narcolepsy with cataplexy may resemble atypical seizure. Patient चल रहा है, उसको पता ही चला where is walking now. And polysomnography has to differentiate. Polysomnography is a sleep study which can very well characterize this pattern. Next is movement disorder. So movement disorder obviously is a neurological condition, degenerative brain disorder there, in which tics, myoclonus, chorea are there which may resemble some seizures. So there are sudden involuntary movements may be misinterpreted as seizure. Consciousness most of the time is preserved. So that is the reason it is there. And movement suppressible or distractible unlike seizures. So sometimes patient को अगर aware कर दोगे तो movement आपकी बंद हो जाएगी. लेकिन movement are repetitive movements are there. ऐसा नहीं है कि during epilepsy एक movement हुआ और 2 दिन के बाद तब नहीं हुआ. when the person is suffering from tics, myoclonius or chorea, it is more or less persistent. तो always be in there, always हमेशा रहेगा, ठीक है. और पेशेंट पहुंच बिल्कुल ठीक सा रहेगा, उसको पता भी रहेगा कि he is suffering from that type of tics or myoclonic jerks or all. Next is metabolic or electrolyte imbalance like hypoglycemia, hyponatremia, sometimes they cause seizure. Hyponatremia is decreased sodium concentration. When the sodium concentration is below 120, which is, then it may cause spontaneous seizures in the patient. So we have to correct sodium, it might not develop seizures again in his life. So associated symptoms, sweating, hunger, tremors, helping to distinguish between the diabetes, hyperglycemia state or hypoglycemic state. And panic attacks and hyperaldosteronism syndrome, they overlap with seizure in terms of sudden onset, palpitation, tremors and numbness. Patient is typically aware with no EEG abnormality provoked by emotional stress. Breathing into the paper bag may relieve when the patient is suffering from panic attack. Panic attack, as the name indicates, it has some emotional or stress background. कुछ हो गया लाइफ में या कुछ फेल हो गया एग्जाम में, किसी की लड़ाई हो गई या फैमिली प्रेशर आ गया, then so many things are there. It is also closely resembled with the psychogenic seizures also. Certain vestibular disorder, vertigo spasm may mimic focal seizure, dizziness and ataxia, and positional triggers are there, and nystagmus may aid diagnosis. So vestibular disorder में क्या होगा, थोड़ा चक्कर आता है पेशेंट को, ठीक है ना, साथ में और पोजीशन रहेगा, जैसे वो पोजीशन चेंज करेगा तो it may recur basically. So you get that means that by which we get diagnosed it is a vestibular disorder. और साथ में उसका आई के abnormal movement रहेंगे, तो nystagmus usually eye movement if it is there, you can say it is a vestibular disorder. And last one is behavioral and psychiatric condition like dissociative episode, schizophrenia, pre-psychotic event may appear similar to the complex past seizure. Hallucination, unusual behaviors or emotional outbursts are made with the diagnosis. ये भी बहुत persistent है patient का behavior. By looking at the patient, you can diagnose कि people is suffering from these type of behavioral conditions. The family history is very important for diagnosing of these illness. So after having the seizure of epilepsy, how it progress? आगे उसका क्या होगा? We'll see in the subsequent slide. So some epilepsies, especially idiopathic generalized type, may remain stable or improve over time. However, other evolve into chronic drug resistant form. तो कुछ क्योर हो सकती हैं और कुछ हमेशा ड्रग डिपेंडेंट और ड्रग रेजिस्टेंट में आते हैं. Transition of syndromes. Pediatric epileptic syndrome can evolve in different types into adolescence or adulthood, like West syndrome evolving to the Lennox-Gastaut type. तो एक syndrome बच्चों में चल रहा तो adult लाके Lennox-Gastaut syndrome हो जाएगा. तो that evolution can be there. Starting कहाँ से हो रहा है, कहाँ तक पहुँच रहा है. Then structural metabolic causes epilepsy associated with the identifiable brain lesion like cortical dysplasia, tumor or stroke tend to persist. ठीक है, ब्रेन में अगर कोई स्ट्रक्चरल लीजन है, you cannot change it unless you do the proper surgery. तो जब तक वो लीजन रहेगा तो it is a epileptogenic focus is there, which may have persistent seizures. Then kindling effect with the recurrent seizure can enhance neuronal excitability, making the brain more susceptible to the future seizures. And drug resistant over time, or because for the epileptic patient we have to give a drug for a longer period of time, and sometimes drug may have developed resistant leading to the use of multiple drugs. And sometimes because of the ongoing over the period of time, brain has received subsequent insult in the form various forms, so that might cause the resistance or the resistance over period of time. The various form, we should know some certain complication of epilepsy. Also, what complication is epileptic patient can have. So, patient, as already shown by your play, quite impressed by the play. उसमें social stigma बताया गया. तो when the patient develops social stigma, patient will land into depression, anxiety, and psychosis normal due to shared neuropsychological subset and some certain chronic disease stress is there. Then cognitive impairment. ठीक है ना, कॉग्निटिव इम्पेयरमेंट if the बचपन से उसको सीजर्स आ रहे हैं तो ब्रेन की एक्टिविटी डिक्लाइन, कॉग्निटिव डिक्लाइन इज देयर. तो मेमोरी डेफिसिट, अटेंशन प्रॉब्लम्स एंड लर्निंग डिफिकल्टी, स्पेशली इन द अर्ली ऑनसेट ऑफ पोorly controlled epilepsies. And cognitive outcomes are worse in syndromes like Lennox-Gastaut and epileptic and sonopathic. तो syndromic diagnosis में जो हो रहा है उसके cognitive decline ज़्यादा होता है. Reading capability, memory deficits might be there. So these are the complications. Next are S2DEF, sudden expected death in epilepsy. So one of the most great complications linked to generalized tonic-clonic seizure, poor adherence and nocturnal seizure. तो what we observe, जो आपने बोला कि फिर एक साइड में कर दो उसको एयरवे प्रोटेक्ट करके रखो, अगर ये प्रोटेक्ट लोग सामने हैं तो कर पाएंगे, अगर सामने नहीं है तो इट में डेवलप दिस टाइप ऑफ कॉम्प्लिकेशन. नाइट में सीजर हुआ, nobody has looked at it, aspirated and gone patient. So this is known as sudden unexpected death in epilepsy that is occurring basically. Then obviously injuries there, सीजर आया, गिर पड़ा तो कहाँ चोट लगी नहीं पता, कभी हेड इंजरी, ड्राइव कर रहा है, एक्सीडेंट हो गया तो डेवलप एंड ही मे लीड टू द डेथ ऑफ अदर पीपल आल्सो who are driving or who was with him during that time while driving. So falls, burns, drowning, accident during seizures are very common. Next is social and occupational impact. You all understand when the patient is having epilepsy, so what social impact can have? So stigma, discrimination, driving restriction can severely impair quality of life. So driving to, if person is diagnosed with epilepsy should not drive unless it is well controlled for a certain period of time, only then he or she would have license to drive. Because they impose the risk of not only themselves and the people who are driving with them, they are at the risk also. And treatment related complications, obviously drugs are there inherent complication, so certain drugs, adverse effects from anti-seizure medication like sedation, hepatotoxicity, bone health issues. Then polytherapy increases the risk of drug interaction and a side effect. Obviously, the many drugs are being used for treatment of epilepsy, and over the period of time, like people having multiple comorbidity along with them, various interaction with the drug used to treat comorbidity may occur and then lead to increase or decrease in the level of their anti-epileptic drug. And if level get decreased of anti-epileptic drug during time, so seizure potential gets increased, it may throw seizures because of that also. So that we have to see while treating the patient of epilepsy. Coming to the after complication, उसका आगे क्या होगा, ठीक है ना, कैसा रहेगा? तो what happened? Favorable prognosis in many cases, 60 to 70% of people with epilepsy achieve seizure control with medication. Prognosis is better in idiopathic epilepsy than those with normal neuroimaging and EEG. EEG or brain imaging normal, the prognosis is good. And poor prognosis seen in early onset of childhood epilepsy, developmental delays, having structural brain lesions and frequent seizure and poor drug response. If it is there, then the patient may have a poor response. Regarding role of epileptic surgery, the patient is having some structural lesion, so surgery may offer a proper cure. And in birth-related dry-resistant cases, like major temporal lobe sclerosis is there. That part of brain is become hard. You can remove that part and patient might be free of epilepsy. So also there is importance of early diagnosis and management. Timely intervention can improve seizure control, prevent complications, enhance long-term outcome, and we can ensure the long-term remission. Some patient may achieve long-term remission and may be eligible for drug withdrawal after under medical supervision. How we are going to this part is for healthcare of people with epilepsy. How we are going to take care of the person who is suffering from epilepsy. This is the role of society we are going to offer to the patient when the patient person is having epilepsy. So first is holistic approach to the care. ऐसा नहीं कि epilepsy को सिर्फ दवाई लेकर ठीक हो गया. दवाई लेना भूल भी सकता है ना, तो family has some role to at least timely medication मिले और proper उसका investigate हो. So it goes beyond the seizure control. Comprehensive care should address physical, psychological and social well-being. Also, mental health concerns such as depression, anxiety and stigma are common and need targeted support. Interdisciplinary care involving the neurologists, psychiatrists, psychologists, social workers, rehabilitation experts like occupational therapy and therapy people are very crucial. Multidisciplinary approach is Then regarding access to treatment, there is significant treatment gap, especially in low and middle income countries. The low socio-economic status might not afford the medication, might not able to investigate themselves for proper treatable cause. And over 70% of the people with epilepsy can become seizure-free with proper medication. And many do not receive treatment due to lack of awareness, inadequate healthcare infrastructure, culture, belief or stigma, and sometimes high cost and availability of anti-epileptic drugs may be one of the that's why there is some difference in access to treatment of the various population. Third is disparity in care, access to quality epilepsy care is inequitably distributed, affecting rural versus urban. You can see the urban वाले को सब कुछ मिल जाएगा, rural वाले को नहीं मिलेगा. And low income individual, children and elderly who would take care of these people. Women with epilepsy may face gender specific barriers, especially concerning pregnancy, contraception and access to care. So these are various things are there we have to address by the patient is. Regarding next is patient education empowerment. As you all have seen the play here, so obviously we all have to make the patient educated as well as feeling to empower, to understand seizure type and treatment regime, avoid triggers like sleep deprivation and alcohol should not be used, and practice seizure safety like during bathing or driving. We have to be very cautious, he should not develop any injuries, and self-management tool and application can aid in tracking seizures and medication, whether he is taking medication in time or not. Also, we have to work on reducing stigma. It is highly stigmatized still and impacting quality of life, employment and marriage prospects. It is but that stigma remains still we are facing here. So what we do, replicate the public education campaign and advocacy are essential to combat myths and promote acceptance to these type of peoples. There is certain role of epilepsy center there. Specialized center may play a key role in the complex case management, diagnostic clarification, whether patient is suffering with daily epilepsy or mimics as we have already seen, and surgical evaluation and advanced therapy option. If it is there, then we have to help him out, and multidisciplinary epilepsy clinic improve patients' outcome obviously. Next is obviously ये अकेला काम नहीं होगा, some certain part government को भी करना पड़ेगा, like the policy for integration, and it should be integrated with the universal health coverage policy. WHO inter-sectoral global action plans calls for improving access, promoting research in epilepsy, increasing community-based rehabilitation, and scaling up training for healthcare providers for this part. So after going this, as the epileptic and are having so much risk, some risk strategies for the prevention of injury. So if the person has to wear a helmet while cycling on horseback riding, no unsupervised swimming. Because during swimming, उसको seizure आ गया, तो obviously he is going to die if somebody is not supervising him. It is advisable to use shower, not to the bathtub, and water temperature control of the hot water heater. So that we have to see a little bit. Use of microwave oven, not a stove. Avoid locking the toilet or the bedroom if the patient is suffering recurrent seizures. The height of the bed should be small in order to avoid possible post-clash injury. Preferably to use epilepsy safety pillow, and be careful of high stairs. Be aware of driving rules for the patient with epilepsy, administration of medication according to scheme continuum. So many things have to be taken care of while dealing with the patient with epilepsy. Some slides for the treatment of epilepsy. I am not going to the drugs per se because it may lead to the more boring part of it. We will just give the idea how the drugs do work. So we have to select the patient for the anti-epileptic therapy depending on the seizure type. Treatment को फोकल है या उसको जनरलाइज एंड स्पेसिफिक एज रिलेटेड थेरेपी को चलना. जितना हमने आपको उसका definition बताया, focal, generalized, absent parts, तो उसके according medicines are there which are acting on the brain to reduce that firing of the neurons leading to the suppression of seizure with the use of these medications. High frequency syndrome like Lennox-Gastaut may require multiple therapies to start with. ठीक है, जिसको multiple seizure और इसको syndromic epilepsy है तो it might need multiple medicine. Where some childhood epilepsy may not need long-term medication, as in case of febrile seizures, जो 6 साल के बाद में automatically most of the 32 seizures में खत्म हो जाते हैं. Diagnosis confirmation is vital. Risk factor for seizure recurrence include abnormal clinical examination, imaging, nocturnal seizure, easy abnormality. Treatment option vary from various seizure types in children such as epileptic spasm with typical absence seizures. Factor influencing choosing the anti-epileptic medication, like what type of epilepsy is there, type, frequency, syndrome, patient characteristics, gender, age, along associated comorbidity, pregnancy, allergies, medication history. So we have to see a lot of aspects of which type of medication is suitable for the patient. That certain drug characteristics like its efficacy, spectrum, side effect, interaction with the other comorbid condition, uses drugs, pharmacokinetic, their teratogenicity, contraceptive interaction. Teratogenicity is needed when the female patient is suffering from epilepsy. That we have to see because of the reproductive age. If the patient is pregnant, then we have to see that teratogenic effect should not transfer to the damage to the fetus. So we have to be very careful giving antiepileptic drug to the female who is pregnant. And obviously some socio-economic factor like their cost, availability, and patient preference. So as a treatment of epilepsy is very poor, we can say multiple years. So we have to choose the therapy which can patient take for that long term. Okay, that's why you have to see the cost also and availability also. आपने ऐसा नहीं कुछ medicine जो आपके पास मिल रही है बाकी कहीं नहीं मिल रही है तो कहीं मैं go another seizure because of that. Research shows for focal seizure, lamotrigine and levetiracetam outperform carbamazepine with the carbamazepine. These are the antiepileptic drugs which are showing that the lamotrigine and levetiracetam these are the like broad spectrum antiepileptic drug. They perform very well as compared to the carbamazepine, which is the older drug. And next is in generalized seizure, valproate is superior to topiramate. Carbamazepine, phenytoin, and formaldol. And for newly diagnosed focal epilepsy, carbamazepine and lamotrigine are preferred. And levetiracetam and param panel shows benefit in treatment of particulars. So in this slide, I have enumerated very few antiepileptic drugs which are given the proper condition to start with. So this table I have taken from our recent textbook of medicine. You can see if the person is suffering from generalized chronic seizure, then first line is drug or only two lamotrigine and valproate. If they are not working, then we can use alternative medication. Then if the patient is suffering from focal epilepsy, so these 4-5 medications we can try on the patient. And on 3 medications you can see typical or absence typically or valproate, ecosystem and laboratory, valproate, laboratory, topiramate are there. In the first line drug and second line drug, they are very, if we follow these, so we can treat the patient very easily. Next is drug resistant epilepsy. Even after use of the definition is when 2 or more appropriate anti-seizure medications fail to control seizure, it is known as drug-induced drug-resistant epilepsy. Various anticonvulsants are available for focal epilepsy treatment, including lamotrigine, oxcarbazepine, and levetiracetam, amongst others. Approximately 35% of patients with idiopathic generalized epilepsy require adjuvant therapy with parampin showing 45 efficacy in reducing seizure frequency. The choice of adjuvant anticonvulsant must consider factors like efficacy, tolerability, and drug interaction. And ideal polytherapy should achieve synergistic effect and infra-addictive toxicity, and combination of very different mechanisms of action are preferred. Because whatever medications are there, they are working on the different mechanisms of action. They should be working synergies so as to give the best effect. Valproic acid and lamotrigine are the notably effective for generalized epilepsy that can enhance seizure control when combined. Alternative treatment for pharmacoresistant epilepsy. If the उससे भी नहीं हो रहा multiple therapy के बाद, then we have to see whether surgery might be required. Neurostimulation, newer techniques like vagus nerve stimulation and deep brain can be offered to the patient who are suffering from drug-resistant. Candidates from receptor surgery must undergo thorough brain surgical evaluation, including VEG, video EEG, or high-resolution brain imaging. Neuropsychological testing aid in assessing pre-surgical deficit and predicting post-operative outcome. PET scan can reveal the hypometabolic area in cases when MRI is inconclusive, aiding the identification of the epileptogenic site. And intracranial EEG monitoring is also available and may be necessary when the seizure field shown is near eloquent cortical regions to confirm the findings. So after giving drugs, तो drug को बंद कब करना? Next question is that when to stop the treatment of the therapy? कब उसको stop? There are certain guidelines are there. So discontinuation of anti-seizure therapy may be possible for patients who have controlled seizure. Obviously, seizure should be controlled, and सब control में चाहिए. Seizure control for at least 1 to 5 years. Single seizure type with generalized seizure having better outcome than focal, and normal neurological examination, no family history of epilepsy, and normal EEG results are there. So we can start thinking of stopping the antiepileptic drug after 1 to 5 years of therapy. The appropriate seizure-free interval is not definitively estimated. Still, we can think. What I told you, we can think of stopping, but what it says, appropriate interval कब हमें बंद करना है, it is not defined yet. कि हमें 1 साल में करना है, 2 साल में करना है, 3 साल में करना है, you never know. A reasonable attempt to withdraw therapy can occur after 2 years. At least 2 years of therapy we have to do, then we can start. And if the other criteria as I mentioned, normal EEG, normal brain response, and normal patient time. And the patient is willing and informed about the risk also. It is recommended to reduce the medication dose gradually over 2-3 months. So we start with after 2 years we can start with gradually capping the dose of antiepileptic drug which patient is taking. Most seizure recurrence happen within the first 3 months post discontinuation, and parents should avoid risky activity during this time. So अगर during first 3 months of decreasing the dose it develop seizure, तो इसका मतलब है कि उसका prolongation automatically 2 साल और बढ़ गया. एक भी seizure आ गया within 3 months, you have to again continue the therapy for more year. So next trial after 2-3 years ही होगा उसका. Rare case shows that patient who experience a recurrence after stopping medication may not regain seizure control with the resumption of these drugs. Sometimes ऐसा भी होता है कि आपने दवाई बंद कर दिया उसका, लेकिन सीजर उससे भी कंट्रोल नहीं हो रहा आफ्टर, तो फिर तो गिव द पॉलीथेरेपी बार सेकंड उसको दोबारा सीजर आया. We have to obviously we have to think another important aspect of the treatment of epilepsy in women and women having epilepsy. One aspect is that pregnancy, as I already spoken. Most women with epilepsy have uncomplicated pregnancy with normal deliveries, so that is good part about it. But seizure frequency remains unchanged, 50%. So chances of seizure can be there 50%, 30% में increase हो सकता है, बढ़ सकते हैं, और 20% में decrease हो सकता है. This is how the data of seizure during pregnancy may occur. Changes in seizure frequency may result from endocrine, because so many hormone changes are ongoing in the patient, so that's why these things are there. And because of that, there is some certain protein binding of the anti-epileptic drugs are there. They can be increased or decreased basically. That's why the seizure potential gets increased in 30% and sometimes decreased in 20%. So regular monitoring of serum anti-seizure drug level is essential. As you can see, the monitoring of drug level during pregnancy. So it is very difficult for a country like us in low and middle income country. Getting drug level, it's quite costly. So this is, although it is written there, but it is very difficult to achieve. The risk of exacerbation increases, the level drop more than 35% from the non-pregnant level. And incidence of fetal abnormalities in children born to mother with epilepsy 5 to 6%, higher than 2 to 3% in the healthy women. So kid को भी suffering हो सकती है सीजर्स की double as compared to non-seizure mother. Teratogenic effect of anti-seizure drug can be there, leading to the higher the fetal abnormality rates risk correlate with the number of medication and doses used. Whatever anti-epileptic drug we are using, they have some teratogenic potential. So we have to use a drug which has less teratogenic potential, so that the fetus should not have any congenital birth effect. So in that, valproic acid is the highly associated with the increased risk of adverse fetal outcome in the tune of 7 to 20%. So we have to avoid using valproic acid during pregnancy. Newer anti-seizure drugs are considered to be safer than valproic acid due to the various registries. Recommendation emphasize maintaining effective drug therapy during pregnancy to prevent harm from the uncontrolled seizure. Preferably, patient should be on the monotherapy at the lowest effective dose, in the first trimester. And sometimes folic acid is recommended to mitigate antifolate effect, whose benefit remain unproven. And enzyme-inducing drugs can cause temporary vitamin K deficiency in pregnant newborn. Mothers should receive oral vitamin K in 2 weeks before delivery, and infant should get IM vitamin K at birth. So vitamin K supplementation is needed both for mother and for kid. So let's see the diagnostic algorithm regarding when the patient presents with seizure. We have to take history, examination. We have to exclude mimics also, like symptoms, PIA, migraine, psychosis, other cause of cerebral dysfunction. We have to see whether the patient is having history of epilepsy, can be treated with drugs or not, or there is no history. Those two aspects are there, and maybe having on the epileptic drugs or no history. If patient is having epilepsy, then you have to follow this algorithm. We have to assess the adequacy of anti-seizure drugs, side effect serum levels. We have to see all the metabolic parameter like CBC, electrolytes, glucose, LFT, KFT, urinalysis, spectroscopy. For saying the treatable cause, if they are normal, then subtherapeutic anti-drug level may be there. Then I have to appropriately increase the level to level for the treatment. Then subtherapeutic means levels are low. If the therapeutic levels are there, then increase anti-drug drug. So we have to increase the dose. Okay? If the levels are low, anti-drug medicine के, then we have to increase the level. और अगर levels अगर normal है, then we have to increase the level, or we have to add another drug to for the prevention of other seizure. अगर test abnormal है, तो depending on the which test is abnormal, we have to correct that. That's all. Next is, if there is no history of epilepsy, the second part of it, we have to do all the tests. Then, if we find any positive in these things, then we have to further work up. Like we have to see lumbar puncture cultures. We have to see the treatable cause and treatment accordingly, right? Then, if the metabolism is normal or negative, and then we have to perform MRI imaging and we have to find the various causes where if there any focus is there or not. If in MRI EEG focal feature of seizure, then we have to go to the next algorithm. So if it is there, we can find MRI or abnormality, we find such a reason like stroke, sinus inspection, trauma, then we have to underline cause. If there is no, so we can label the patient is having idiopathic seizure and anti-seizure therapy has to be initiated in the subset of patient. Aspect is the status epilepticus, जिसमें continuously seizures are without any break, फिर में is a life-threatening condition, so in which we have to use we have to in emergency we have to follow these medication flow so that we can control this condition and later on we can put the patient in the proper anti-epileptic drug. I'm not going to have this detail. So my last few slides. So by going this epilepsy presentation, we can come to know that epilepsy is common and treatable neurological disorder, catarrh, recurrent, unprovoked seizure. The broad spectrum of seizure type and epileptic syndrome exists, requiring precise classification for optimal management. Accurate diagnosis through detailed history, EEG, and imaging is crucial. Misdiagnosis can lead to unnecessary treatment. Treatment is individualized. Most patients respond well to anti-epileptic drugs. Others may require surgery, neurostimulation, or sometimes dietary therapy. Timely intervention, regular follow-up improves outcome and quality of life. Psychosocial support is essential to address stigma, improve adherence, and ensure holistic care. Patient can lead normal life with proper management, education, and awareness. And multidisciplinary care, awareness campaigns, and inclusive policies are vital to support people with epilepsy. With this, I thanks all of you for patience hearing. Thank you very much.